Hello everyone, welcome to the next in our COVID update community conversation. I'm just going to check that we've got as many people as need to be, and the team, Nadine and Tanya, are there from Health Consumers Council. They're going to keep an eye on the chat function and also making sure that other people can join us as they go. I'm delighted to be, I'm actually here, as you can tell, but I'm sitting at another device just in the interests of trying not to be too confusing, although I suspect that that might not be the outcome. But thank you so much for joining us today. And, you know, the year has really started again with a vengeance. I'm not going to talk too much longer, but I just wanted to say a couple of things. Thank you to Grant, who, and I'll introduce him briefly, but he can introduce himself. But as many of you will know, this is the Grant's third update that he's done with Health Consumers Council for the community, and we're really grateful that you make the time available. Thank you for that. And I also want to just acknowledge that where Grant and I are joining from, we are joining from Wajak Nungar Buja, and pay my respects to elders past, present and into the future, and acknowledge that sovereignty was never ceded, and that at Health Consumers Council we continue to sit with the outcome of the Voice referendum and continue to reflect actively about what that means for us as an organisation that exists to ensure that people have a voice in the issues that affect them. And so that's something that's very much a live issue for us, and we look forward to working with our stakeholders, consumers and community as we go forward on that journey together. We'll make a start. So thank you very much to everyone who registered and submitted questions in advance. The way that the session will run today is that we will we'll hear from Grant in just a second. He's going to give us a little bit of an update of the latest evidence in science. And then we'll go through, we've kind of themed and looked at the questions that have been submitted in advance, and we'll go through those questions. And then Nadine and, like I say, Tanya are also monitoring the chat to see if other questions come up in the moment. We're going to have another one of these next month too, so we know that this remains to be a live issue for the community. So if we don't get to all of your questions just now, we will continue to try and get them answered. So I'm Claire Mullen, I'm the Exec Director at Health Consumers Council. And if you don't know about Health Consumers Council, we're an independent organisation and we celebrate 30 years this year. And we exist to provide an independent voice for the community and consumers on all aspects of health. And one of the ways we help to do that is by creating these opportunities so that the community can hear directly from senior WA health leaders and clinicians about the issues that are important to you. So I'm delighted Professor Grant Waterer has a number of roles in his, I think the bulk of your day job is Director of Medical Services at East Metro Health Service. And so I'm going to hand over to Grant just to give us a bit of a latest update, and then we'll get into some discussion and questions.
Thanks. I'll just
and hold on, we'll just make sure that Grant can share, so I can do that here.
We're just trying to share my slides. So
yep.
In terms of my role today, I'm really acting as a professor of respiratory medicine whose core research and expertise is in lung infections. So here, okay. Just so you know, I do work with all the pharma companies that are in this space: GlaxoSmithKline, Moderna, Pfizer, AstraZeneca. As my conflict of interest, I personally believe that we need to work with the pharma companies to make sure that they do the trials they should do and guide them, and that's why I work with the pharma companies. So I will have shown this slide before to some of you. Normally in a pandemic, what we see is an initial infection that comes out of season, and then it merges into our winter season, and generally over the course of 3 or 4 years just becomes part of the normal milieu and stops being such a big problem. And if we look at what happened with swine flu, so that's back in 2009, the pink here on these graphs is the amount of swine flu we've seen this is in Spain, but the same data is in Australia, that every few years swine flu continues to be a significant part of the annual influenza season. And this is what you would normally expect to see when a new virus enters into our system. But we didn't see that with COVID. And what we've seen is progressive waves of infection, and we're in a minor wave again now. The reason for that is that there is more SARS-CoV-2, so the virus that causes COVID, in replication in the world than any other virus in the history of mankind. And these viruses, like coronaviruses, they're designed to break. So in our cells, every time a cell replicates, the error rate is about 1 in a million, or more than 1 in a million. The error rate when a virus like SARS-CoV-2 replicates is about 20% every time. And it's, dividing several times a day. So you've got gazillions and gazillions of mutations occurring all the time. And while most of those mutations are junk mutations, they're not helpful, sometimes they're deleterious to the virus, every now and then the virus gets lucky. And it gets lucky in terms of either the new variant is either more infective, and that's what we saw early in COVID, these more and more infective variants, or now it's a variant that is not as susceptible to the immunity we get from prior infection or the immunity we get from vaccines. So there is this global race amongst the individual virus mutations to see which one can become the dominant. And as we develop some immunity to the dominant strain, then there will be other mutations in the background here that are going to surge to the front. And that's what we've seen time and time again with COVID. And if you look, and for those of you who are a bit nerdy like me, there's this great website, www.nextstrain.org, that tracks all the mutations as they're detected. And what you can see is that starting with the original strain, all these different families of mutations that have occurred. A little easier way to look at it's presented by the CDC. And what we saw was this explosion of strains after Omicron came in. And to the dominant strains, for example, like JN1, which I'll show you in a second, which is a daughter of the Parola strain that got a lot of press last year. But all of these new variations are all ones that are mutations of prior strains that are all competing to be the most effective to elude immunity or vaccination the best. Omicron was particularly important because if this is a sort of a schematic map, if you like, of how different was each new strain. So if we go to the original strain, the Wuhan strain, Covid19 alpha was only a little bit genetically different. Delta a little bit genetically different. But Omicron was vastly different to the strains that had come before. And that meant that Omicron really escaped all the immunity that had been acquired by exposure to these prior infections and the initial vaccines that we had. And subsequently, the XBB strain, which is what the latest variants of vaccines have been designed against, was as different from the Omicron strains as the Omicron strains were from the original phenotype. And this XBBs, they came around about 12 months ago, and the new JN1 strain is about as different again. And so the virus is going through these big jumps where it's quite antigenetically different, meaning that prior infection and prior vaccines aren't quite as effective against them. And this is, so the CDC in the US tracks all the strains. And if we look back in November, this is US date, so they're backward, they put the month before the day. If you look in, a late November, early December, HV1, JN1 was starting to come up, EG5 was on the way out. If you look in the last few weeks, you can see that in the US, overwhelmingly it's JN1, and there's a few, you know, this JD 1.1 strain maybe is, you know, still there, but somewhere in this pack, there is probably a strain that's going to become predominant as JN1 is exposed to a whole bunch of people and immunity starts to develop to it, something else will occur. So one of the big questions is what happens next? And as Niels Bohr said, prediction is very difficult, especially predicting the future. But in reality, there's three real possibilities. The first is that we will continue to get small increments, small little variations that are just a little bit more infective or just a little bit more escape, and we'll continue to see that evolve. Stepwise evolutions means sort of bigger jumps, and that's like jumping from the original strains to Omicron or Omicron to JN1, where we have big jumps, and those big jumps are likely to be associated with a big surge in infections. And there's no doubt that we'll also continue to see some of those as we go along. Again, because there is so much virus out there in the world replicating, the sheer number of mutations means that it's inevitable that some of these jumps will occur. And then I guess what we all fear is that there might be a huge evolution of the virus, and when that occurs, when you get a lot of changes in the virus, that's when potentially you could see it become much more virulent than the current strains. Death rates could go up, hospitalizations could go up. And that is the big fear, that there's a really major jump. And what's the likelihood of that? It's very hard to put a percentage figure on it. It's certainly well and truly less than 50%, but I wouldn't say it's less than 5 to 10%, simply because, again, we have so much virus out there. So that's the evolution of the virus and how it's evolving and why it's evolving and how it will continue to evolve. Then there's this question of people say to me, well, I got COVID again, clearly my vaccine isn't working. And there's some really important things to understand here. The first is that this is a graph, and what it shows is that before COVID, when they were studying coronaviruses, down here is weeks, and what you see is that for common strains of coronavirus, up to 70% of people would acquire the same coronavirus every year. What that tells you is that our body's immune system is not very good at creating lasting immunity against a cold from coronaviruses. So unlike infections like measles or smallpox, where we tend to get lifelong immunity, for coronaviruses, a bit like some of the other things that cause common cold, like rhinoviruses, our immune system is not very good at producing lasting immunity to what I will call mild infections, okay? So colds, fever, snuffy noses, feeling miserable. I mean, a bad cold makes you feel absolutely horrible. And so if our own immune system is not very good at giving us lasting immunity from getting infection, it's quite unrealistic to think that vaccines would do any better. Because with vaccines, we're really giving a much lower dose than a normal infection. The next thing to understand is how important the spread of the virus is in causing disease. So when you get COVID, it goes into your sinuses and your upper throat. You inhale it, or you touch it and you touch your face. That's how we get these viruses. And when you get infection in these areas, that's where you get the sneezing, you get the sinus pain, you get fever, your throat gets sore. In very, very few people with coronavirus, the virus will go straight from the upper nose and throat into the lungs. And that's maybe 5% of the severe disease we see. In most people, the virus has to get into the blood to cause all the damaging stuff. So the deaths, all this immune problems you get, all the lung failure, all the heart damage, all the kidney damage, all the brain damage, all the gut damage, all of that is caused by virus getting into the blood and it doing its thing in the blood or in the organs. Now, the good thing about vaccination and prior infection is, and this is just me schematically showing, that immunization gives us an awful lot of immunity in the blood. Doesn't give us great immunity in the nose and the throat. And it doesn't give us very long lasting, as I'll show you, immunity in the nose and the throat. Whereas it does give pretty long lasting immunity in the blood. So with COVID, we have this situation where you get a lot of virus in the nose and the throat, where you don't get a lot of long lasting immunity. And that's why people are getting COVID twice a year, because they're getting infection, they're getting the nose and throat, but because they've had vaccination and because they've had prior infection, when the virus does escape into the blood, it gets mopped up by the immunity. So people are still getting sick, they're still getting a bad cold, but they're not dying. They're not ending up on ventilators. They're not ending up with heart damage. They're not ending up with brain damage, because the vaccines are preventing severe disease. And that's a really important concept to understand, particularly when people say to you, well, you know, I got vaccinated and I still got COVID, the vaccine didn't work. Well, the vaccine did work because they didn't end up on a ventilator and they didn't end up dead. But our current vaccines, our current vaccine technology is not going to prevent what I'll call mild symptomatic disease, a cold, because our body's immune system doesn't work that way. Now, they are experimenting with giving vaccines via an inhaler or a nasal spray, and it's possible that down the track, our approach might be both a needle injection and an inhaled injection. But for the moment, with what we've got very good protection against severe disease, but not great protection against mild disease. So it's the viremia, the virus in the blood, that kills you. And the circulating antibodies that you get mop up that virus and protect you. And vaccines produce a lot of antibodies in our blood, but not a lot in our nose and throat. Okay, so vaccines will stop dying. They won't necessarily stop you getting a cold. Just to demonstrate that kind of effect, this is data that came out before Omicron, but just to show the impact of both age and vaccination. So if you compare blue unvaccinated men with vaccinated men, over here you can see that the effect of vaccination was to drastically reduce the mortality from COVID. And you can also see the effect here of age, that, you know, the curve starts to go up at 60, but from 70, it's really going logarithmic. And that is the same for a lot of viruses, influenza, RSV, for which there's a new vaccine. That there is something profound that happens to our immune system somewhere between 55 and 70 that starts to make us much more susceptible to viruses. Herpes zoster or shingles is another example of that. And this impact of age is very important. Now, as I said, the protection against infection with the new strains was not well preserved with the older vaccines, although the older vaccines were still producing enough antibodies in blood to stop severe disease. So what we were seeing is this. And so this is data from the UK that shows you, so the squares here are Delta, the circles here are Omicron. And what this is comparing is people that had 2 doses of an mRNA vaccine versus 3. And this is for symptomatic disease, not severe disease. So what it was showing was that the vaccines at 6 months were still giving reasonable protection. So 60%, our current influenza vaccines are about 40% effective. So 60% still a pretty good result. That was with 2. And with 3 doses of mRNA vaccine, you're talking still 90% protection for Delta with the original vaccines. But for Omicron, it was very clear that protection was dropping off. And so even by 10 weeks, you're getting down to around 50%. So it was clear that we needed, you know, some new vaccines to prevent symptomatic disease. But even then, if you look at hospitalisation or death, the older vaccines were still giving excellent protection against bad disease. They were just giving not great protection against symptomatic disease. So we had to start chasing the new variants. And so there was the original SARS-CoV-2 strain vaccines, of which there was about 6 or 7. We then got the bivalent vaccines, meaning that they were formulated against the original Wuhan strain and the newer Omicron strains. They came out in the end of 22 and into 23. And now we've just had released the XBB 1.5 monovalent vaccines, which are formulated against XBB 1.5, which was the dominant strain a year ago. And what we know is that this new vaccine also gives good antibodies against strains like JN1, which is the current dominant strain. So these vaccines are going to give good protection against severe disease, meaning hospitalisation, death. But you would expect, because of the way the body's immune system, that against symptomatic disease, they will still only have that 2 to 3 month high protection against symptomatic disease, and people will still get a cold.
Did I interject a question here on that slide? The Moderna and Pfizer, so that's the same Moderna and Pfizer, or is that a new variation of Moderna and Pfizer that has come out in 23-24?
So there was the original version, Moderna and Pfizer.
Yep.
Then Moderna and Pfizer brought out strains against Omicron, and now they brought out against X. So there's that. We're really into the 3rd generation of vaccines.
Thank you.
And all the companies are now into the 4th generation of vaccines, chasing JN1. But it'll be 4 to 6 months before we see that.
Thank you.
In terms of, so as I said, all the studies suggest that the current XBB1 vaccine has good efficacy against all the current circulating strains. And in terms of side effect profiles, again, it's arm pain and fever. The main thing that is that with the mRNA vaccines, especially in younger males, so by that I mean 15 to 25, there is a rare incidence of myocarditis, meaning inflammation of the heart. It can occur in other settings, but it's mostly younger males. The important thing to know is that if you get COVID, the risk of myocarditis is 20 to 50 times greater in that group.
Right.
So I'm not going to pretend that the vaccine is 100% safe because this occurs. But if you're going to the casino, your bet is going to be on having the vaccine if you're worried about myocarditis, because you're much more likely to get myocarditis with COVID than the vaccine. The other thing, because I saw some of the questions, is around personal protective equipment. And just by the by, this is in the Museum of Berlin. This is a plague doctor's helmet. They used to put herbs in the nose here. Wearing masks and avoiding people who are sick works. This is data before COVID. This is during SARS-1 in Hong Kong. And what this graph shows is that 0 is the normal frequency of these common infections. Hepatitis B, the blue line here, is something that's spread by basically contaminated water. So you wouldn't expect it to be affected by masks and social distancing. But all these other infections are respiratory infections. And what you can see is during SARS-CoV-1, when people were avoiding people who were sick and wearing masks, is that all these other viruses disappeared. And we saw that worldwide. Influenza disappeared for 2 years. RSV disappeared for 2 years. Pneumonia rates were a fifth. Interestingly, stroke and heart attack rates were a fifth, because a lot of strokes and heart attacks are precipitated by viruses. And this is WA data. And this grey line and this dashed line are hospital admissions in normal seasons. And you can see how dramatically hospital admissions dropped for respiratory infections during that period of close lockdown. So simple hygiene measures work. And one of the disappointments, I guess, is how quickly that has been dropped off by many people. And I think the challenges in this space are sick grandchildren are absolutely a major cause of spread of infection, but we're living in a society where it's very difficult for many people to avoid doing that. When you have so much COVID around, stopping the spread of COVID in doctors' surgeries and emergency departments in hospitals. So, we put masks on people who are got respiratory symptoms, we try and keep them isolated, but we don't have the facilities to do that at the highest possible level because we're overwhelmed and busy all the time. And so spread of COVID within those environments is a problem. Our vaccination rates and our revaccination rates are dropping. There is vaccine fatigue. People are not getting vaccinated. The failure of people to isolate when they have COVID. I know people who caught COVID and jumped on a plane to go on a holiday because I don't want to cancel my holiday. And the level of selfishness, and it's all about me, and failure to do one's community good is a real problem for us. I think most workplaces are now pretty intolerant of someone turning up to cough and sneeze, and that's a good thing. But there are many people out there who are not doing the right thing. And yet the failure of people to wear masks, especially when they're coughing and sneezing, is a real problem. In Australia, for example, if you go to, as I was recently in Taiwan or Japan, lots of people still wearing masks all over the place. Culturally, it's an accepted thing to do. Here, we are not doing that. And then I just wanted to turn briefly to long COVID, because I know there's a lot of questions about it. And long COVID is very confusing for many people because it's not one thing, okay? Long COVID is not a disease. It is a collection of an absolute grab bag of 1,000 things that are people are trying to put into one bucket. And so I divide it up into, there are very clearly people who have detectable organ damage, meaning if we look at their lungs, if we look at their heart, if we look at their brain, if we look at their kidneys, we can find detectable damage related to COVID. And they have ongoing symptoms and problems related to that organ damage. Overwhelmingly, they are 99.9% unvaccinated. And they're people that have had severe disease, typically needing to go to the intensive care unit or at least prolonged hospitalizations. And they are the vast minority of people where we can find detectable organ damage. Then there is a whole cohort of people who have no detectable organ damage. And by that, I don't mean that I'm not saying that they don't have a problem or they don't have side effects as a result of COVID. What I'm saying is that there is no medically available test that can find an abnormality. And equally, frankly, there's also no medically available therapy. Now, what we know about this group that don't have detectable organ damage is if you're unvaccinated, you're vastly more likely to get something that will be diagnosed as long COVID. We know that it's 4 to 8 times more common in those who have depression or anxiety pre-COVID. And we know that it's 2 to 5 times more likely in those who have pre-existing lung or heart disease before COVID. So that doesn't mean that you have to have those things. It means if you have those things, you're more likely to complain of long COVID-like symptoms. In terms of its frequency, the frequency in particular of the chronic fatigue, brain fog type syndrome is very, very similar, if not identical, to people who've had significant influenza, significant pneumonia, a significant hospitalization of some other event. Whether they're related to long-term changes in the immune system or the sleep-wake cycle or brain chemistry, we don't know. But there's nothing unique about COVID here. It is very similar to other processes that we know about. There is some pretty good evidence that graded physical exercise and time, that the vast majority of people improve. There are clinical trials underway, but as yet there's no proven drug that has been shown to make any difference or is worth the side effects of those drugs to improve symptoms. That doesn't mean there aren't case reports of people trying this or trying that and it's worked for them. What it means is there are no big trials where you can say, right, 200 people who have this symptom, if you give 100 this drug and 100 you don't, that after 3 months, this many people are better. There is no such trial, okay? Otherwise, we would have drugs underway. And so this is very, very difficult for everyone to deal with because there's no test that you can, if you don't have detectable organ damage, there's no test. And equally, there's no proven treatment. And so this is both frustrating for patients and it's also frustrating, obviously, for doctors. So what does all this mean? It is inevitable that we're going to see COVID evolve. There is far too much of it replicating out in the world. We're going to see more variants. JN1 will not be the last variant that we have. This will not be the last wave. If we're lucky, we will never get a big evolution of it so that we get a really damaging, highly virulent, highly lethal form emerge. But more waves is inevitable. Personally, I think we're stuck with an annual vaccine for the foreseeable future. And by that, I mean decade or more. Those who are very high risk, so the very elderly, those with a lot of comorbidities, it may well be that it's more often than that. So 6 monthly, which is kind of being what the recommendation is. And at the moment, there's just not enough data to know how long the current vaccines are giving high level protection against severe disease in the current, with the current variations that are around. It is just evolving too fast for us to collect the data with all the variables. And so we will see recommendations refined as time goes on. I think it's also probable that in those who are at very low risk, so those who are never going to get severe disease from COVID anyway, so the young, the fit, it may well be that they only need a vaccine every 2 or 3 or maybe even 4 years just to keep enough antibodies in their blood that they don't get severe disease. And so I think over the next 24 months, 36 months, we'll see recommendations that evolve around, annual vaccine for most, 6 monthly vaccine for high risk, low risk, maybe slightly more often than that. And that's what I would expect to see happen. I think community vaccine fatigue, and especially the basic hygiene fatigue, are major threats to all of us. I think we all have a role in trying to actively address that and try and counter the, well, I know that you've got your holiday booked, but if you've got COVID, frankly, it's not okay to go and sit on a plane with a whole bunch of people and spread it. And that is a societal issue rather than a medical issue. And so I will stop sharing my screen there and take questions from Claire and others.
Oh, Grant, thank you very much. There was a couple of comments there already about how you've really helped to illuminate some of the topics in ways that people haven't seen it before. And I think that's really important because other comments are that there's so much information out there and so much of it seems almost conflicting. And I have to say, personally, I don't have a Master's of Public Health. I cannot work out the information on the Health Department website about vaccinations. I have the luck of working in this area, but I do think that we can do more generally to try and make this information much clearer. So thank you very much for doing that. Now, there's also a whole heap of questions that have come up, including some that were submitted in advance. So first up, with regards to long COVID. So obviously, as you've outlined there, you've outlined the reasons that might speak to why long COVID clinics are being discontinued. But what advice for people is there if people are experiencing what they would experience as long COVID? And one thing that came up for me there was, you mentioned about clinical trials. Out of session, are we able perhaps to find out a little bit more about these so that we can help direct people towards those clinical trials? And if in the absence of the long COVID clinics, what is the advice? And I know, again, we're talking about some systemic issues that are not within your control, but with access to general practice being so challenging for many people at the moment, what is the advice if people have these symptoms that they would like to get help with?
All right. So the first thing is, as a general medical principle, you always start at first principles, and you don't assume anything is long COVID just because someone's had COVID.
Yeah.
And so, the symptoms that would be really worrying are things like breathlessness, chest pain, a big change in functional status. So, I can think of a few people that I've seen who, before COVID, were able to walk 3 times around their local park, do 4 or 5 kilometers, and now they can only manage 500 meters. That is a flag for needing to look to find a cause.
Yeah.
So if there is a real change in functional status, it needs an explanation, and that needs to be properly investigated. And, you know, there are basics around that. There's checking your oxygen level, there's doing a chest x-ray, maybe having some sound wave test of your heart. And so I think if you had a change in functional status, particularly with regards to your exercise tolerance, if you're getting pain, those need to be investigated and not assume that they're COVID. It's much harder when we're talking about what I would call the softer features of long COVID, the sleep disruption, the memory disorganization, the you know, inability to concentrate, those kind of things. Again, you know, a general practitioner should screen for all the common causes of that. And then at the end of the day, unfortunately, there is not at the moment a lot of treatments that are available. What we do know is that, you know, graded exercise, getting regular sleep patterns, eating healthily, and time, the vast majority of people after 12 months are back to baseline.
Right.
So again, I get back to, if symptoms are getting worse rather than better, it needs investigation.
Yeah.
Reduction in function needs investigation.
Yeah.
And then the sound common sense principles that apply to almost everything in life, you know, try and get regular sunlight and exercise, try and have a regular sleep pattern, try and eat healthily. Those are certainly not going to do any harm.
Yeah. Okay. And so look, out of session, we will pull together a few resources based on what Grant has talked about, and maybe we can follow up with you about those clinical trials that we can perhaps also, because there's a couple of people who I think are describing scenarios that would definitely fit into that, needing much more investigation. And I guess my take would be too that our current clinical system is sometimes challenging for some of those chronic fatigue sort of conditions, because, like you say, it doesn't lend at the moment. Medicine doesn't have a way of investigating that to the satisfaction of people who experience it.
Medicine's not perfect, okay? We don't have answers for everything, and if there's not a test that can give a diagnosis, and there's not a treatment that's proven to work, then you're in a very difficult situation.
And look, again, from a Health Consumers Council point of view, one of the things we're interested in this space is around citizen science opportunities, where often people who have conditions that are, if you like, not yet well tested or treated by conventional medicine, citizen science is often a way to start to push some of those boundaries, but with a science lens. I'm not talking, you know, anti-science, but sometimes citizens are the ones who have to be the ones advocating for change in that area. So watch this space. The other thing then about vaccines. So I guess there was a few questions that we had submitted in advance about the protection of people who are vulnerable. There's a couple of groups in particular. One is we were talking just before we got started, and to let people know, this is information in the public domain. Currently, West Australian aged care homes have the lowest level of vaccination rates in the country for COVID. So that's aged care homes, the lowest level of booster vaccinations. And it's my understanding that there are no active programs in place. Knowing that, how important is it that people in the community advocate for themselves and their loved ones in terms of getting access to vaccines?
I think it's absolutely essential that everyone does everything they can to have everybody who should be vaccinated. The community herd immunity to reduce exposure is one of the key benefits of vaccines. It's not just about protecting the individual, it's about protecting everybody. It is certainly true that the older you are, the more diseases you have, the less efficacious that the vaccines are. Vaccines have the best effect in young, healthy people, but they don't have no effect. You know, I'd say it's a bit like seatbelts, okay? If you're a 100-year-old, a seatbelt in a car, you're still likely to have significant damage because your bones are brittle, etc. But would you put a 100-year-old in the car without a seatbelt? No, of course you wouldn't. And so, you know, just because the 100-year-old might get 70% protection rather than 95% protection is not a reason to not give the vaccine. And the only way we're going to stop this endless cycle of mutations and more waves is to reduce the amount of virus that is replicating in our communities. And vaccination is the key strategy in that.
Thank you. Now, with another question about vaccination of children. So at the moment, young children under 5 are not currently eligible for vaccination. What's your stance on parents being allowed the choice to get their children under 5 vaccinated?
So, as I wasn't involved in the decision making, that's the Australian there's an Australian advisory group that advises on children, and the decision was made, as I understand it, that the data that children need to be protected from COVID, unlike influenza, is that young children don't get severe disease from COVID. And so on a risk versus benefit basis for that individual, it was decided not to recommend it for very young children, but to wait until they're a bit older. That does cause some problems, of course, in that if the children can still get COVID, can still spread it to others. And, you know, if they've been looked after by grandparents, etc., that's an issue. But the current national recommendations by, you know, a group of people that are collectively much wiser than me was not to recommend it in Australia. So I would have to back that group.
Yeah. And then there's another group, obviously, people who get little or no benefit from vaccination, either because perhaps they're on medications like, now I don't know if I'm going to pronounce it, like infliximab and methotrexate, but also people who might also have severe immunocompression for other reasons. What are any new and emerging information that you can share about protections for that group? And one question's been asked specifically that we're understanding if you shield or if you shelled is not effective for the current variants. Do you know of any new preventive work that's in development for that group who can't get the benefit of vaccination?
Okay, so the first thing is that certainly with the mRNA vaccines, there is no possibility of acquiring the infection from the vaccine. So with a lot of traditional vaccines that were an ameliorated virus or the whole virus, there were people who could get harmed by a vaccine because their immune system was so damaged. That is not a risk with the mRNA vaccines, that there's no whole virus. And so the data is that in all these immunocompromised people, whether you're on infliximab, methotrexate, cyclosporin, that they still get some protection from the vaccine. So I don't know of any group where it's a complete contraindication to have one of the mRNA vaccines. With respect to Evershield, those were sort of a collection of antibodies, sort of like giving you a passive immunization, if you will, and correct that it was formulated against the original strains of COVID and really is not effective against the current strains. In general, there hasn't been further development of those products because the virus has been mutating so quickly that the cost of development and production can't possibly keep up with how fast the virus is vaccinating. We do know that Paxlovid, which is the antiviral, in groups that are at high risk of bad COVID, and especially those that are perhaps immunocompromised, that it does reduce the risk of developing severe disease, but it's not as effective as, say, an antibiotic. If you've got a strep throat and you get an antibiotic, you can pretty much guarantee 98%, 99% of people will be fine. You know, with Paxlovid, we're more talking about reducing the risk by a third. So it's still worth having, but it's not magic.
Right. And there's a question there about Paxlovid. As we understand it, it's got a relatively narrow set of criteria.
Yes.
Do you see any possibility of that being broadened and being more available? I happened to see the AusSage submission to the COVID inquiry, and one of the things that they had said is broadening the access to that kind of treatment.
It's possible. I guess what's got to be weighed up with there is, so if we look at influenza, where we have Tamiflu. The Tamiflu was given so widely that, you know, more than half the influenza strains are now resistant to it. So the more often you give something, the more likely it is that the virus will mutate so that it's no longer effective. So the expert group will have to make a decision between, do we preserve it and limit its use so that it remains effective in those who are going to get the most benefit from it? Or do we spread its use so more people might benefit, but the virus will become immune to it much faster? And that's a difficult decision to make.
Yeah, and it's all, and that's where we get into, again, the role of the community and consumers in being having a strong voice in those conversations, so that because I know often that what comes up, and obviously in the very early days of COVID, there was a lot of conversations about, you know, before vaccinations, about rationing and what's going to happen. And I think our interest is making sure that the voices of people who are most likely to potentially be negatively impacted by those sorts of decisions
Have a voice.
Have a voice in influencing those decisions. Can I there's one more question about so if somebody can't have Paxlovid or Paxlovid because they have long QT syndrome, what's the alternative, and is it as good?
So the only other orally available antiviral for COVID is molnupiravir, and to be honest, it's not very effective, and it's no longer basically used. If you get severe disease in hospital, we can give you intravenous remdesivir, and that would be used. But unfortunately, if you've got long QT syndrome, then Paxlovid is contraindicated.
Right.
And again, I would say you have to remember that Paxlovid is not a miracle drug. So, you know, if you had a bacterial pneumonia and we couldn't give you antibiotics, you're going to die because it's antibiotics or death. With Paxlovid, it's a small reduction. It's not a wonder drug that changes everything. So while it's disappointing that you couldn't have the drug, it isn't like it's a death sentence or it's made the result inevitable.
Yeah, thank you. To go back a little bit, so we talked a little bit there about long COVID, but can we talk a little bit about multiple infections? So you talked there about, and that's the first time I've also heard it described, about the different levels of immunity in your nose and your blood, and why people might therefore think, and I definitely hear anecdotally a lot, oh, COVID is just a bit like a bad cold, a bit like a flu. But we have also been hearing potential evidence around the impact of multiple infections in, if you like, otherwise healthy people. And certainly from my point of view, I guess I see that as a mechanism to support community understanding of the importance of protections, which is, you know, the whole what's in it for me. If everybody thinks, oh, actually, I don't want to get it more than once, I might be more inclined to follow the protections with masks and social distancing. And how important, what is the issue with regards to multiple infections? What's the risk there?
Okay, so there's no evidence that if you get serial COVID infections that COVID will be worse or better. So in terms of how often you have it, it doesn't seem to affect the outcome of COVID itself. But what we do know is that any significant infection is associated with other deleterious effects. So most of you have had a really bad cold, know that it takes 2 or 3 months to get back to your normal self. We know that any serious infection associated with higher rates of heart attack, it's associated with more falls. We know that, particularly if you're a vulnerable elderly person who's maybe just coping at home, that a significant viral infection, be it influenza, RSV, COVID, can be the thing that means you end up in nursing home care. There's no question that having serial significant infections is not good for you. You know, it's like running, it's like keeping your foot down on the accelerator of the car. If you keep the car engine revving at high revs all the time, things are going to wear out. So, you know, it would be better if we had less infections. There's no question about that. And so anything we can do to prevent it, we should. Having said that, it's not like if you have 2 COVID infections in a year, you're suddenly now 100 times more likely to have something bad happen to you. Maybe it's 12% more likely or 8% more likely. But it is still, you know, I would like to avoid as much COVID as I could. Thanks very much.
Yeah, I have to say, the more I learn and continue to learn, that is absolutely a guiding principle. So a couple of things, we're getting close to time. There's a couple of strands of the discussion. One is, a lot of what we're seeing is about the data that's available. Now, obviously, in the information that the Federal Health Department produce, or even the WA Health produce, they still are saying about COVID infections, but we know that they're not collecting the same level of data that they were before. So do you know if there's any plans or any examples internationally where there is better surveillance or better data? And again, from an advocacy, my interest point of view is like, you know, I can see a need for Health Consumers Council to be a voice saying, how can we possibly understand this illness well enough if we're not collecting the information about it? So that's one thing is, you know, how else can we improve the data that's collected? And then staying, if you like, on tests, how is testing happening on hospital wards as a matter of course? And then in the community, we're hearing from a lot of people that it's actually really hard to get hold of rats these days. And that if you can, you're getting them from a chemist and they're almost $10 a pop, I think, which is, you know, so it's a challenging time. So there's a couple of things in there. The access to tests and what we should be doing about how we do that. And then the data that tests can give us, how can that help improve this, you know, going forward?
So apart from a very few countries, no one's mandating testing anymore, and they're relying on tests that are done in laboratories to keep a track of what's happening. We do have Perth, like everywhere else, does surveys of wastewater, and so you know we know what strains are around from that, and that is a pretty good surrogate for tests because
And does it also cover prevalence as well as strains?
Well, it covers strains, but it covers prevalence in that you get a kind of a global measure of how much there is.
Yeah.
So you can kind of estimate.
Right. Okay.
And I guess, you know, for countries as well, tests cost money. And so if a test isn't going to change something, you know, do you do a whole lot of tests, or do you employ 20 extra policemen or 20 extra teachers? Those are decisions that government have to make in terms of where they invest their money. I'm not too fussed at the moment, to be honest, that we've abandoned routine testing in the community. In that I think the only people that absolutely should be tested are those where it may affect their travel plans, or those who might be eligible for Paxlovid. They clearly need to know if they've got COVID. We do routinely test everybody that comes into hospital who has any kind of respiratory symptoms, because for us, it's an important infection control measure. So all hospitalised patients get routinely tested.
Right. And so then staying in the healthcare setting, we've got a couple of issues about consumer rights in this space. So as far as I'm aware, the mandate for masks in high-risk environments is still in place. But we do hear stories of people where they've asked, and they may not have been in a high-risk environment, but they themselves know that they are at higher risk, and they've asked, would staff please wear a mask? And staff have declined, shall we say refused. In that kind of, again, we're trying to provide information to the community to support them to both self-advocate and also for us to advocate at a community level. What I was hearing from you saying is that masks are important and they are a good protection. Any reflections on masks in healthcare settings, both either in high risk or otherwise settings?
That's a really complicated one, isn't it? That kind of policy would be set by government on the basis of advice from public health.
Yeah.
I think when there's a high level, particularly when we're in surges of COVID, I mean, recently we went back to using masks in all clinical areas.
Right.
When it's at a very low level, probably the most important thing is the person who's at risk wears a mask.
Yeah.
There are practical difficulties as well as some financial difficulties in using masks always in all settings. So I think it's kind of got to be a horses for courses kind of discussion.
Yeah.
I think it's a very difficult question to answer as a yes, no, because it depends on how much COVID's around, it depends on the setting, it depends on the person's risks.
Right.
But I would always hope that a clinician, and by that I mean a nurse, a doctor, whoever, would be receptive to people who are particularly high risk.
Yeah. And look, I think it's a broader question, isn't it, about that relationship between clinicians and consumers, where somebody does know their level of risk, but that might not be fully appreciated by the people around them. The other thing then is obviously there are groups of people, as you've outlined, that are at greater risk both of the acute infection and then potentially longer term. Do you have any thoughts, or again, are you seeing anything internationally about changes in making it easier and more financially viable for people who are in those categories to access things like PPE or tests? Because I know, there are, like you were saying, the only people who need to get tested are in that particular environment. I know that, N95 masks aren't inexpensive. Tests are for $10 a pop, and if you want to make sure that if people are coming into your home, that they're, as to the best of your ability, you can assess that they're COVID-free. Anything that you can share or reflections on improving people's, where they're at high risk, and that is known and understood, that people can get free or low cost access to things that will protect them from severe disease.
So I think different governments around the world have taken different strategies, and even from city to city, area to area within countries, there are different processes. I guess within Australia, you can get the test done free under Medicare, but that means having to see a GP and one of the things I advocate with my patients, I have some chronic lung disease patients, is I'll give them a form for a test if they get COVID, so they can go to a laboratory and get it, and they don't have to see me. Rat tests have their own problems as far as sensitivity, as far as how long they're viable for. And when we all thought we needed an awful lot were bought.
A lot were given away as well.
And again, that gets back to a decision way above my head about where do you spend your money. But I certainly think that people who are at risk and where there would be a recommendation to take Paxlovid, I try and make sure they've got a test so they can go to the laboratory and get a swab.
Right. Great.
Masks, again, in some settings, masks are still offered in some of the Scandinavian countries, for example.
Right.
An N95 is probably not needed unless you're actively dealing with someone who has an active infection.
Right.
Probably normal surgical masks are fine in that setting.
Right.
Of just casual social contact.
Yeah.
And of course, even an N95 will fail if it's not used properly, if you don't know how to use it.
Yeah.
And so, frankly, if you're that high risk, if someone's actively coughing and they don't know what they have, they shouldn't be seeing you.
Yes, and look, we know that there's a group of expert patients who, are very aware of their risks, and so get their masks fit tested and everything. So look, we've reached time. I know that there's still some questions that we didn't get to, but I think we've covered a fair bit of ground. So all that really remains for me is to say a huge thank you to you, Grant. Like I say, Grant has been a great friend to Health Consumers Council and the community about, as you've heard today, sharing information in a really accessible way. I think what is very clear to us all is that we are going to continue to learn about COVID. I have to say that information at the start about the spread of how present the virus is in our community compared to others was illuminating. And so we're going to continue to learn from it, and at Health Consumers Council we'll continue to try and provide opportunities for you to hear directly from people. There's an evaluation form going into the chat just now, and we'll send it out again afterwards. We will put the recording of this on our website, and we will share the slides with Grant's permission. Thank you. And look out, so we are planning another session next month, the 11th of March, where we will be hearing from Dr. Andrew Miller. So we'll be sending information out to you about that. But for now, please join me in the traditional Zoom way of thanking Grant Waterer for your time today. Thank you very much. Zoom
Thank you,
way.
Claire.